Welcome, everyone, and thank you for joining us for today's session, Frequently Asked Questions on Multiple Myeloma Following Relapse. I'm Mary DeRome, Senior Director of Medical Communications and Education at the Multiple Myeloma Research Foundation. I'm joined today by Dr. Brandon Blue and Nurse Dana Spiak from the Moffitt Cancer Center in Tampa, Florida, and their patient, Natasha Cooper, who is from West Park, Florida. They're here to answer your questions about relapsed and refractory multiple myeloma. So first, we're going to talk about, I'd like to welcome everyone here. Thank you for being with us. Really appreciate you participating in our Facebook Live today. It's really great. So we're going to start talking about what happens when treatment no longer works. So Dr. Blue, is there any way to predict if a patient will experience a relapse, whether it's their first relapse or their fourth relapse? And does having certain cytogenetic abnormalities play a role in relapse?
Yeah, so the big thing about relapse, especially when it talks about multiple myeloma, is that it happens for everyone. So we have not, as of March 2023, found the cure, right? So that means that regardless of whatever we do, the disease will come back, okay? For some folks, that's years and years in between, and some folks, it's only months, but it does happen for everyone. There are a certain group of people who have what we consider high risk multiple myeloma, which means that the cancer cells actually have mutated in a way that actually give them somewhat of a survival advantage. So unfortunately, that means when cancer cells survive, unfortunately, that means that the remissions are shorter and not as deep as we would have hoped. And so that does happen from time to time. But that wouldn't be the vast majority, but just know that, from a prediction standpoint, I would say that, the prediction is that each person is individual, but just know that it will happen at some point, but it shouldn't necessarily something that keeps you up at night or give you extra anxiety. It should be something that, the doctors are able to follow because you're coming in for regular visits, and we'll be able to kind of tackle it the first time that we see that the disease may be waking up again.
Mm-hmm. Great. So Dana, speaking of relapse, what tests should patients follow to be aware of potential disease reoccurrence? Or to put it another way, which test results would indicate that the patient needs to be on a different therapy?
Yeah, so we look at, we do blood tests. So those include blood chemistry, liver function. We look at immunoglobulins, kappa lambda light chains, their ratio, and specifically M-spike. We also look at the bones, so we do that with imaging, whether it be, a PET scan. Sometimes patients can't do that. It's an MRI or a bone density test. And then we look at the bone marrow itself to see, how many of those bad cells, the plasma cells, are within the bone marrow.
Great. So Natasha, we're going to go to you now. Thank you for taking the time to be with us today. We really appreciate your time. So can you tell us how you found out that you had relapse from your treatment?
Those blood tests that Dana is speaking of.
Mm-hmm. So you follow your results regularly. When you come to visit the doctor, you always follow your results, and you understand what it means when these numbers go up or down or whatever, right? So, okay. So
absolutely.
So can you tell in any way other than the blood tests that you were having a relapse? So did you experience any physical symptoms that might have told you were relapsing?
No, and that's the scary part.
Yeah.
I didn't.
Mm-hmm.
Nothing.
So then when you went to the doctor and got your lab results back, it was kind of a shock, huh? Yeah.
Yes.
Mm-hmm.
Absolutely.
Okay. So Dr. Blue, yeah, it's a shocking thing. So, So Dr. Blue, we've been learning on our webinars about the importance of achieving the deepest remission possible with initial treatment, and that includes achieving minimal residual disease negativity. So I've got a couple of questions for you regarding MRD. So can patients who have relapsed from initial treatment still achieve MRD negativity with their next treatment?
Yeah, so that's really one of the exciting things that's happening with myeloma is us trying to get not only people's what we call light chains to go down to normal, And not only for people's bone marrow to be cleared, but actually people to get what they call MRD negativity. And really what that means from the most advanced way of us picking up myeloma, can we detect it or not? All right. If we can detect it, that means someone is MRD positive.
Mhm.
But there's some people who we really can't detect it by whatever superior means that we have in technological advances. We just aren't able to detect it. I will give people the caveat, though, to know that even though somebody is MRD negative, it doesn't mean that they have zero cancer cells. And the reason why that's as important is because even if you only have one cancer cell, one will turn to two, two will turn to four, four will turn to 10. Okay,
Yeah.
and that's how this cycle starts up again. It
Right.
just means that it's below our level of detection. And the
Mhm.
good thing about it, Mary, is that our ability to detect gets better and better every couple of years.
Mhm.
So, right now it may just be us able to detect 1 out of 1 million cancer cells, but at some point, hopefully, we can detect 1 in 100 million cancer cells.
Yeah.
So
Mhm.
each couple of years, things are getting a little bit better and better. So for sure, that's something that it's always our goal is to get someone in MRD negativity, and that can happen even in a relapse setting.
Yeah, yeah. So thank you for that explanation. I know that I was talking to one of our folks that talks to patients, and they said that the patient told them that their MRD was 1,000 cells in 1 million, and they were asking if they were actually positive or negative. And I said, well, that's actually pretty positive.
Yeah,
So you have to get down to like one or less
yeah.
to be negative. So okay, let's see. Okay, so the second question is if a patient who achieved MRD negativity after initial treatment becomes MRD positive sometime thereafter, is that considered to be a relapse? If they just go from negative to positive?
Not necessarily, but that is potentially a sign to say that maybe things are starting to change, right?
Mhm.
Again, these are cancer cells, and cancer cells, as a principle of them being cancerous, they like to grow, you
Mhm.
know? And so, despite of whatever we do, whether that be medications like lenalidomide, pomalidomide, daratumumab, all these wonderful medicines that we have, those cancer cells would still like to grow. And so you may notice that you went from undetectable to now detectable, but your blood work still looks fine, your bone marrow is still doing fine. And if those things are still intact, it could potentially still be several years before those things become detectable and before it's actually considered a relapse so that someone would need to change treatment.
Mhm.
So is it important to know? Yes. But is it a panic mode or something that would necessarily need to change treatment? No, I wouldn't say that.
Mhm. So is it very common practice at Moffitt and at other academic medical centers for people's MRD levels to be measured after initial treatment and after subsequent treatments to see how effective the treatment is? And is it as common for MRD to be measured in the community as it is in like a major academic medical center?
Yeah, so that's a two-part question. So I'll answer the first part. So, really, we believe that we're here to help people, right? Like, as the doctors, it's our goal and our job to really inform the patient as much as possible, okay? And so as a patient, you may have a question, how long, we did this great job of maybe getting the disease under control, even sometimes even doing a stem cell transplant. And now you say, all right, you want to do this maintenance, but how long will this last?
Yeah.
We typically need some kind of information to be able to give you to tell you what we think. And typically that's where MRD plays a role. You can tell, just like the person you were referring to, if they have 1,000 copies of their
Mhm.
cancer cells,
Mhm.
we would expect a certain amount as opposed to someone who only had one copy, So, there's levels to the depth of disease control. And so we expect different levels of remission based off of those depths. And so, it's just something that's an extra tool in our tool belt just to help give people more information about what's going on.
Sure.
Now, the second question you asked is this done everywhere? Is this something that is readily available at my doctor down the street? And I would just say from our standpoint, we work very closely with the community doctors to let them know the importance of these particular testing. So Is it something that can be available? Yes. Is it something that your doctor has done for you if you have multiple myeloma, or done for your loved one? Possibly. But you know what? The only way to know is ask, right?
Mhm.
And so listening to webinars and things like this information that we're doing here will really be able to educate you and say, hey, I heard about this MRD. Have I been tested for that, or do I have that? Those are things that are super important. And if there's ever any concern, we always recommend that if someone is seeing a doctor in the community, it never hurts to get a second opinion,
Sure.
especially from someone who's considered to be a multiple myeloma specialist or
Yes.
at a large academic center.
Hmm. Absolutely. So that's something we try to reinforce in all of our patients. It's especially important because multiple myeloma is such a complicated cancer. And it's really so difficult to keep up with all the new advances and all the information. So unless you're a doctor who really specializes in multiple myeloma, then chances are you don't know all the really new stuff unless you've gone way out of your way to really learn it. So we do recommend that patients at least consult with a specialist every time that they relapse or when they're newly diagnosed.
Yeah, because that's it's the thing that makes it tricky. I'll just tell you,
Mhm.
when people have things like breast cancer, they can
Mhm.
feel a lump in their breast and they say, hey, this shouldn't be there.
Right.
Make it go away, doctor. Or, there's people who are diagnosed with colon cancer. They have
Mhm.
blood in their stool and they say, hey, they look back there and they say, that shouldn't be there. Make this go away, doctor, right? People who have prostate problems or prostate cancer, they have difficulty urinating. Those issues don't happen with multiple myeloma, right? You may have fatigue, you may have back pain, you may have some of these common conditions, and that unfortunately things get missed because
Yeah.
there's no specific thing to point to any one condition and say,
Right.
oh, aha, this is multiple myeloma.
Mhm.
So, the things that, Natasha was saying as far as relapse, those are things that, us as the doctors, we're very in tune to what necessitates disease relapse. And if you're not in tune with that, sometimes that's where things get missed. I'll also say that from a patient standpoint is very important because I tell all my patients that I think it's very important for you to be in tune with your own body, right? For you to know how I feel right now. And when we talk and we have our doctor visits to say, hey, I don't know what's wrong, but something's off, or I feel
Mhm.
different, or my
Mhm.
body is telling me something, because it could be some of those subtle changes that really make the biggest difference. And so,
Yep.
That's just what I would say that, disease relapse is a scary thing. And again, I'm looking at it from the other side of the table, but Natasha can speak more about that. But just be in tune with your body and listening to your body, I think plays such an important role.
Yeah.
Now, I'd
Agreed.
like to kind of piggyback off that as the nurse, as Dr. Blue's primary nurse. I go in and I assess the patients every time they come in, and I need to be listening to what they say, because it could be the slightest, oh, this weird thing happened. I have this, pain here, or, they're not able to control their bladder or bowels as well. Those can be signs of disease progression.
Mhm.
Tumor plasmacytomas on the spinal cord, things like that. So it's just listening and, keeping an eye out for those things with the
Right.
patient.
Right. Agree. And patients also need to know that they have to really communicate with their healthcare team in order to get the best care, right? If they're having some kind of symptom or some kind of side effect, these things need to be communicated to the care team so that you can help them, right? Because if you don't know what they're going through, then you really can't help them, right? So Dana, we talked a little bit about cytogenetic abnormalities earlier. So, but if people have those, can the ones that they have change when they relapse? So, for example, if you are newly diagnosed and your cytogenetics, which is like your DNA, is examined, and no abnormalities are found, can you then just like get an abnormality when you relapse? And is it important for patients to keep track of that information? I know it's a little bit technical, but.
Yeah, so sometimes they can with treatment.
Mhm.
Your cytogenetics can change, but typically, there's two important things that the physician will look for and follow with cytogenetics, and one being translocation, like 1114.
Mhm.
With these two things, the doctor is able to recommend specific treatments. There are certain medications that only target specific translocations. So that's what that's what the doctor will choose as treatment, and the cytogenetics, if it's, high risk or not. Again, certain treatment regimens depend on those things. So then that falls back to the doctor to decide, what's best for the patient.
Mm-hmm.
Yeah. So, but, I also think, to answer the second part of the question too, is it something should people keep track of? I always recommend that people are as knowledgeable about their disease as possible. Sometimes, again, like you said, this is a very complicated thing. It's almost like having science class again. And some people, they haven't been to science class in 20, 30, 40 years, but just, even if you don't know the technical terms for them, you could potentially at least just say, hey, I know that, there was something different about my cancer, or, you can put it in whatever terms as possible. But I think to say that, do I need to know every specific translocation? I think that's always ideal, but always to let someone know, at least I know I'm high risk, or I know that I have, a certain mutation that Dr. Blue told me about, so I think those things are very important. And it's always something that I always recommend that people educate about, because, you have to lie there and get these bone marrow biopsies, right? So at least you should know what they say when the report comes out.
Right. Oh, that's true. So, Natasha, did you have once you were on treatment, did you have certain expectations about how long your response would last to the treatment that you were on?
So, initially, I was actually on 2 lines of treatment before, and they were not working out. At least they weren't going in the direction that Dr. Blue wanted them to go into. And so initially I did have some expectations about how long this would be, not knowing a whole lot about it. But like Dr. Blue said, I quickly started researching and educating myself, because when I looked at what myeloma was, multiple myeloma was, I didn't fit the criteria. So I'm trying to figure out how I ended up with it. No cancer history in my family or anything like that.
Mm-hmm.
And according to what I read, it definitely shouldn't have happened to me. So in educating myself, I started doing a lot of reading. I joined some groups on Facebook, because I felt that it was important to know, because like he said, there is no one thing that happens, and I did not initially feel any. When I look back, things that were happening, I thought it was just age. I'm 52 years old, and I was diagnosed almost 4 years ago. So I was in my late 40s. So I thought it was coming with age and being overweight. So some of the things like the backache, the shortness of breath, from time to time, I felt like I needed to lose weight and things of that nature, not knowing that it was brewing, if you will.
Right.
And by the time that they got to it, like I said, I had already failed 2 lines of therapy. And so Dr. Blue was just like, yeah, I want to try, you should try this. I want you to try that. And I had to take follow his lead,
Sure.
because he's the expert. But definitely knowing more about the disease, and I learned more about it on a day-to-day. And I know that this is, a forever fight for me.
So good for you for going out of your way and doing that research. So it's really such an important thing for patients to do. So Dr. Blue, since many patients are treated with like a 3-drug regimen and relapse occurs, and this is a question we get from a lot of patients. So if patients are on 3 drugs and they relapse, so how do you know which drug wasn't working that caused the relapse, or was it just a basic failure of everything at once?
Yeah, so there's different ways that people relapse, right? So typically what happens is that what we find, just similar to what Natasha was saying, is that people, when they first get diagnosed, like they don't know that they had this. And typically it's not like the first thing on anybody's mind, right? They went to their primary doctor, the primary doctor sent them to that person and this, so the stories of how people got diagnosed with myeloma, I tell you, can be very complex. But by the time they get to us, it's typically like, hey, there's a good amount of cancer that are there, and we can get this under control. So in order to do that, we try not to just hit the cancer one way. We hit it from the left, the right, the up, the down, so that that cancer does not have any way of moving, right? Like it has no way to go but down, okay? And so when that happens, there's what we call different mechanisms of action, meaning that each drug actually kills cancer a different way. And you don't know which one will fit like a lock and key and actually be the magical one that basically kind of does most of the heavy lifting. But at that point, it kind of doesn't matter because you need the cancer to go away. Okay. And so that's why we do that. And it's probably not really one drug, but it's probably the combination because they, to some degree, help each other. Okay. And then what happens is that the cancer goes away. Again, sometimes people do what they consider to be a stem cell or bone marrow transplant. And then we say, well, the cancer's gone now. Let's put you on some type of maintenance program. So then we choose some very low level of treatment to kind of keep people on. But then there's two ways that the disease shows itself. The disease can have what we call a biochemical relapse, meaning that we see the M spike go from 0 to 0.1 to 0.5 to 0.9, and we notice that those, what we call kappa and lambda light chains, may go from 10 to 20 to 50, and things are slowly happening. However, there's also people who say, hey, doc, my back is hurt and I've never had back pain before, even with the first treatment. We look and do an MRI or X-ray or something, and they have a new fracture, or they have what we consider to be a lytic lesion or some type of bone involvement that was not there before. That's a big problem because the way that we treat those two scenarios is very different. If someone has this slow progression, meaning that the numbers are kind of just ticking up and up and up, we have time. We have time to figure it out. We may even repeat the bone marrow biopsy. We need to figure out the best kind of course of action, and we have time to do that. If someone is coming to you because they're in significant pain from a new fracture caused by the cancer, you need to help that person relatively immediately, and how you treat that person is very different. So the type of relapse typically dictates what we do, how fast we do it, and the sense of urgency.
That's great. So Dana, Dr. Blue was referring to lines of therapy. So, and this is another common question that we get from patients. So can you define what a line of therapy is?
So a line of therapy simply is just the treatment regimen you're currently on. Sometimes patients, see multiple lines of therapy. So they see multiple different treatment regimens. Like you're saying, when a patient relapses, the disease is no longer under control. It's starting to progress. So the treatment regimen, the line of therapy that they're receiving is going to change. And, maybe a new medication's added or everything's changed completely.
Natasha, what can you tell us about the treatments that you've been on, and what responses did you achieve, and what side effects have you experienced?
So, I think like the first line of treatment, I started out with Velcade, and Dr. Blue, you can help me. Velcade and two others, and then I went from that to Velcade, Kyprolix, and something else, and then the second line of treatment, I had what was it?
Yep, the Revlimid.
Yeah, Revlimid, and I didn't really get any I don't want to say like side effects. When I got to Dr. Blue, I'll just preface by saying that I was already like at stage 3, right, Dr. Blue?
Mm-hmm.
Wow.
Because I don't even know how long it had been brewing, like I said, and
Hmm.
I 70% of my bone had liquid lesions.
Wow.
Um, and so yeah, Dr. Bruce said I was already at stage 3. So none of those. I mean, those first 2 lines of therapy, uh, they did a little, but then my numbers would come down and then they would go back up, and so it was doing that yo-yo kind of thing.
Mm-hmm.
And um, after that second line, and he didn't see, I was kind of stagnant for a while. He mentioned about the clinical trial,
Oh.
and I got in a clinical trial.
Mm-hmm.
But honestly, I don't recall having many besides the fractures that I did not know that I had until I had like the MRIs and things of that nature, the PET scans, the bone densities. I did not know them, so that would be the only thing that I really remember complaining about. I had a lot of rib fractures. I could sneeze and break a rib or
Sure.
fracture
Mm-hmm.
something.
Mm-hmm.
Yep.
Mm-hmm. Wow.
Um, uh, as far as any other thing, I really didn't have any side effects or anything like that.
Well, it's important to
You
know
can
too
say
that
that, right, Dr. Blue? I didn't complain.
I'll tell you that Natasha, your case was a little bit different. You can tell the people about it because one of the things that Natasha got was something called CAR T cells. Okay,
Oh, you
and
had a CAR T?
Right.
Wow.
and so
Amazing.
and so she got it
Yes.
on a clinical trial when it was before it got approved by the government. So
Mm-hmm.
she was one
Mm-hmm.
of the ones that the government
Right.
used to approve it and basically
Mm-hmm.
say, "Wow, this works so well for people. Let's make it available for everyone else." So you can maybe tell them about the CAR T process and if you had any side effects or what your
Okay.
experience was with that, because I imagine a lot of people
Okay.
listening may have not had that done yet, and they're probably curious on how you felt during that process.
Yeah, that would be
Oh,
actually really helpful, Natasha.
okay. So once I got in the clinical trial for the CAR T, I'm probably Dr. Blue will say that I'm their poster child because I came in full stage 3, and then I got in the CAR T clinical, and then I was worked up for everything, and then I got COVID.
Oh God.
I got COVID, or right when I was supposed to get my cells
Oh,
back, and the COVID, I actually tested positive from March until August. So I couldn't really get any treatment.
mm-hmm.
Yeah, I had no symptoms, but I was testing positive.
Mm-hmm.
And so from March to August, it was kind of slow, a slow pace. I couldn't go I couldn't get any chemo, and they couldn't move forward with the CAR T. Finally, I got a negative result,
Mm.
2 negative results, and then they rushed me in, and the process went really quick. I got my I got my cells
Wow.
back, and that was an experience
Yeah.
because I I did go through the is it CRS, Doctor
Yep,
Blue,
yep.
Oh yeah.
the
Cytokine
fever?
release syndrome is what we
Mm-hmm.
call it, but
Yeah,
sometimes we use the
yeah.
abbreviation CRS. Yep.
So I experienced that. I was running fever right after for maybe 2 days, and then I
Mm-hmm.
got the Tussaluba. Tu- tu- you know what I'm saying? The medication.
The
Yep. Yep.
tocilizumab, right?
Yep. Tocilizumab.
Yes,
Yep. It worked very well
that
for
one.
you.
Mm-hmm.
Yes. But that's probably the only side effect that I did have. I will say that for whatever reason, divine intervention, whatever, um, I did not experience a whole lot of bad things with this disease thus far. Besides being let down by the relapse, not the 2 lines of therapy not working, but since I
Right.
got the CAR T,
Mhm.
And I followed Dr. Blue's rules and stayed in the home and things of that nature, and followed the rules of the trial. Um, I've been I I don't want to say, I think that I was MRD negative when they did my first follow up. I had a deep response, and it'll be 3 years that I've been in remission in August.
Wow. Oh, that's great. And you're not on any other treatment, right?
No, I'm not. No maintenance.
Wow, you are a poster child. That's amazing.
Yeah.
Wow.
But the
Okay.
clinical trial was, I think, the best thing that Dr. Blue could have done for me, suggested, recommended. And like I said, I was definitely just going to follow his lead because he's the expert.
Well,
Mhm.
listen, I thank you. And like I said, I'm just glad things are working out. You're doing so well.
Thank
That is
you.
great. That is great. I mean, you hear a lot of stories for people who have CAR T. For some people, it works great. For some people, it kind of works. And then for some people, it doesn't really work at all. So, and it's not the easiest treatment to get because there's just not that much availability. Although if you're in a clinical trial, that's not quite as bad. But then you have to put up
Yeah,
with a lot of monitoring. But that's okay too. So,
yeah,
um,
absolutely.
let's see. So, Dana, we cover a lot about the efficacy of drugs on our webinars, and we also cover side effects, which are many. So, considering that some patients may experience multiple relapses and be exposed to many different drugs, what can be done to minimize the overall impact of drug side effects on patients?
So that's kind of part of my job, like through education,
Mhm.
educating the patient when they're about to start a new drug regimen, educating them about the drug, the possible side effects, how they're managed, what to do if they arise. We always say call us so that we can assess and determine what to do next. Another thing is more prophylactic treatment. As far there's certain drugs that we know have side effects, such as like Revlimid. It can the risk of blood clots, DVTs. So
Mhm. Mhm.
patients are put on blood thinners, such as aspirin. And then things like Velcade, it can cause shingles. So patients are put on a cyclovir, an antiviral medication to help prevent that from happening. So there's certain things we know that there are possible side effects, so we treat those preemptively. But other than that, just through education and following up with our patients and
Mhm.
making sure, we do what's called copy calls after we prescribe Revlimid.
Mhm.
So we make sure, one, that it's doesn't cost a lot for the patient. We don't want them to ever, have to pay too much. But then also the side effects. They could be, rash is a big side effect of Revlimid, and sometimes patients are like, oh yeah, I just, this thing under my arm, it's really itchy, or my scalp started itching, and that's one of the main side effects. So through that, we educate, take the Zyrtec, Benadryl, antihistamine, something like that.
Mhm. So, Natasha, I know we talked about the clinical trial that you're on with the CAR T. So, can you talk a little bit about what your spouse or caregiver, did for you during that time? So, it's a pretty intense process to go through that. So, can you tell us a little bit about that?
So my caregiver was my oldest son,
Hmm.
and he unfortunately, it was the time when COVID had just hit the scene, and so I did the majority of it by myself. I was in the hospital by myself. I had my tablet where I could see them,
Hmm.
video call and
Yeah.
things of that nature. But I was in the hospital for the 2 weeks alone.
Hmm.
And so I basically was on my own. And now, after I was discharged and I went home, my son made sure that I went for my appointments, my follow ups, and things of that nature. And like I said, they give you this information packet about the CAR T and things that I needed to do afterwards. And I pretty much followed it to a T with the help of my son. Um, It wasn't as difficult because I was a good patient. I mean, I really wanted to kick this cancer's butt. So I did everything that I was supposed to or that I was asked to do.
Mhm. Good. It's great that your son was there for you like that. It's a good job.
He
So,
loves his mama, that's why.
oh, that's great. Okay, so let's talk a little bit more about some of the common questions that we get from patients. So, Dr. Ballou, is maintenance therapy used as a part of treatment for disease or for relapse, rather?
So, each time the disease turns active, then the first goal is to get it back under control, Um, and so I'll always think about it as like, if you have, I don't know, a pot that's overspilling, the first thing is to do is you got to get the lid back on, okay? And so typically, we don't use, because typically for maintenance, we use typically a low dose and maybe only one type of treatment, but we don't do that to put the lid back on. Typically, that's just not the best approach. We typically use multi-drug therapy to be able to contain the disease and likely get that person back into remission. But once the lid is on, then you have options. Then you can say, hey, things are back to a simmer. How do we keep it simmering for the next foreseeable future? Okay. When it comes to things like CAR T, then the lid itself will typically do the job.
Mm-hmm.
CAR T is also in its infancy, meaning that like it's only been approved for a very short period of time. So we don't really know how well maintenance will improve the amount of time that the disease is under control. But outside of that, almost every other disease relapse and treatment typically needs some type of help to keep it under control.
Right.
Okay.
Mm-hmm.
And that's where maintenance comes in. But it gets tricky because not everybody's disease is the same way, meaning that there's some people who have so aggressive myeloma that you are nervous as the doctor and even as the patient about stopping some of the treatment. You're like, wait, we just got it under control. How do we back off? But then there's other people who are begging and say, how much longer do we have this treatment? I'm ready to dial it down. You know what I mean? And I think that's where the conversation happens between the doctor and the patient, because
Sure.
sometimes if you do it too soon, unfortunately, the disease basically isn't low enough to basically continue to simmer. And unfortunately, you may see a rise again. And sometimes you hold on to too many medicines too long, and unfortunately you beat the patient up in the meantime,
Yeah.
where it was too many drugs for too long a period of time, and that's not good for quality of life either. So there's not one cookie cutter recipe to say, hey, this is what you need to do, but to know that really maintenance is a part of myeloma treatment. So even after your doctor, you guys high five or you ring the little cancer bell, just know that there's likely going to be some type of treatment that's still coming, because that's just how myeloma is controlled. Some type of maintenance typically keeps it under control longer than without.
So is maintenance true? Like maintenance therapy is given to people who are on a CAR T, like Natasha after she had the treatment, and do patients who go on to bispecifics, which is another newly approved therapy, do they have maintenance therapy?
So, right now it's typically under investigation. So the people who are getting maintenance after CAR T is typically on a clinical trial. So there's no maintenance that right now is currently approved by the government to say, hey, this is what we consider standard of care. CAR T itself is almost like a replicating way, because these cells are alive, and these T cells recruit other T cells to basically kind of do somewhat of a surveillance. Okay. So we don't know if adding maintenance to CAR T helps. Like, that's an unknown question, but something that's being answered with clinical trials. So outside of a clinical trial, that's not standard practice. As far as the bispecifics, So these bispecifics really just got approved Thanksgiving. So we're talking about just a couple of months of approval. And right now, the way that they're giving is until disease progression. So you can continue on them, just getting them and getting them and getting them so that they continue to fight until, unfortunately, the disease grows despite your best efforts of giving the treatment. So some of these newer treatments, again, the jury's still out on how to best control them. But there was a period of time we didn't know to give maintenance after transplant. Like there was, technology and modern information and medical knowledge had to grow to understand and realize, oh, what if we actually gave them something afterwards? They actually do much better. Mm-hmm. So we may see things like that down the road for CAR T, where we're learning more about it. But the jury's still out, and so that's why I think it's important to again go to a myeloma specialist, because there's so many things that change so quickly in this disease that you got to be on top of whatever is considered the latest and greatest.
Yeah. It's kind of interesting. Lately I've seen some commercials with I guess it's patients who have breast cancer, and now they're developing drugs, which we would call maintenance drugs, right, for patients who have breast cancer. And they just, in the commercial, they just talk about taking a medication to keep their breast cancer from coming back, right, which is basically what maintenance is. So it's interesting to see how that's, I don't know if that was something that was actually started in myeloma and has gone to other cancers, or if it started in another cancer and the same idea came to myeloma. But
well, it's actually a lot of cancers that actually do maintenance programs because, for someone to look you across the table and say your cancer is cured, we need to be confident that this disease is not coming back, right? Yeah. Or for somebody to look you across the table and say, this is an incurable cancer, the next question in your brain is going to say, well, how long can it stay away, right? And is there anything to do about it? And we want to make sure that if there's something that we can do, that we do that. Now, sometimes that's contrary to what people's intuitive brain thinks, because they're like, Doc, we were successful. We rang the cancer bell, like the cancer's gone. You're like, well, again, that kind of goes back to my original discussion of, undetectable doesn't mean gone. And so, we just do the best that we can to try to, again, keep the lid on the myeloma, and, maintenance plays a big role in that.
So another common question that we get, Dana, is that now that we have 2 CAR T cell therapies approved and a bispecific antibody therapy approved, and they all target the same target on myeloma cells, which is the B cell maturation antigen, or BCMA, right? So what is the difference between like a CAR T and a bispecific, and how should patients decide which one that would be the best for them to get along with their care team?
Right. And first off, it's the patient with the care team, the doctor, discussing this. With CAR T, there are 2 different ones that are used here specifically at Moffitt, the Abecma and Carvykti. Both can be an intense process. There's a lot of pre-testing that you have to go through. As Natasha mentioned, she had her son, but you need a caregiver typically for about 30 days. You are inpatient. Some can be outpatient, but mostly inpatient, and the risk of side effects. Some can be very intense. So some patients just aren't physically fit for that. Their functional status is poor, even age, those things come into consideration. The bispecific, again, is new, but it's not as harsh. You can have like the CRS, kind of more, it's flu symptoms kind of, but a little bit stronger, body aches, fever, chills, nausea, vomiting, things like that. So with the CAR T, it is a one-time, treatment regimen, and then once completed, you're not on any therapy. So some patients like that. They don't want to they want a break. But the bispecific, it's continuous, as Dr. Blue mentioned. It's until disease progression. So it's a weekly treatment. So you'd have to come in here, or your local physician's office, and get treatment every single week. So it's different. And with those factors, you just have to speak with your care team.
Right. and decide what which therapy really is best for you based on your disease and your quality of life issues, things like that. So it's a complicated discussion. So and considering, Dr. Blue, that these therapies are basically attacking the same molecule, right? The same cell surface antigen that's on the myeloma cell. If a patient is taking a BECMA and then they relapse from that, would they be able to respond to CARVYKTI and or a bispecific that's against BCMA?
Yeah, so that's a good question. And again, because these therapies are new, a lot of these things are done under investigation or in research purposes. There's a lot of people and a long list of people who are still trying to get their first CAR T. So sometimes it makes it difficult to give someone even a second CAR T when a lot of people haven't even gotten the first, right? That's one thing, just because, as you mentioned earlier, availability is the big issue with CAR T. But I'll say that's where the research is going, is trying to understand that. I know at Moffitt, one of the big things that we're trying to understand is, what happens to the people who still have BCMA or B cell maturating antigen still present on their myeloma cells. So you say, well, if they have it, that's still a target, and we have a medicine that could potentially target it, makes sense, right? And so I would say that right now, that's definitely where the research is going. And we're definitely trying to answer those questions. And I would imagine probably within the next short period of time, we should have some of those answers.
Yeah. I mean, a lot of presentations that we see now at ASH or whatever talk about sequencing of these therapies and how effective they are if they're the first one, and then how effective they are if they're maybe the second one after an original BCMA targeting agent. Some of that data is pretty interesting. So I'm sure that we'll get those answers pretty soon. So a lot of trials ongoing there.
I agree.
Okay, great. So we're getting close to the top of the hour. So I have one question left for all of you. So here's the final question. So what can patients or their caregivers do to prepare themselves for the inevitability of relapse? Natasha, I'll let you answer first. But don't forget to go off mute. She's thinking.
You're on mute, Natasha.
You're on mute, Natasha. There she is.
I'm thinking. To prepare for a possible relapse, what can I do, or my family, or whoever my caregiver will be? I don't think you can prepare, because I think at the 3-year mark for me, I'm just starting to try to live or be what I consider normal as I was before this whole thing started. I'm just starting to get back to that. So I don't think you can ever prepare. But I know that communicating with my son, like even now, my son doesn't even live in Florida, and I call him when I go to see Dr. Blue. We get him on the video so that he's involved and he knows what's going on.
Oh, nice.
Because he thinks he's my father, but that's my thing, is being open and communicating with my son and with Dr. Blue about what's going on. I'm very, I ask a lot of questions. I really do, because like I said, I never know when. And I think like the thing that kind of hit me the most, my last visit in the BMT clinic, before I went back to you, Dr. Blue, and I had a visit, and I questioned, since I was still in remission, I said, can I get this thing taken out, this port? And that was the biggest wake up call for me, to know that this is an ongoing thing and it's not going anywhere. And it was like, okay, reality kind of socked me in the gut and said, no, there is no cure. I'm on borrowed time. And that the inevitable will happen. So I can't say that I'm prepared. Like, in the back of my mind, I keep that thought that, okay, at some point it could happen. I
Mm-hmm.
don't know when, but
Right.
in the meantime, I'm just living my
Mm-hmm.
life to the fullest as I can. And so I think that just by being very open with my loved ones, and communicating is the best way to prepare,
Yeah.
and not being in denial, which I've never been. And I don't have these great expectations of, oh, these doctors are miracle workers, things of that nature. I'm a very spiritual person, and I have my faith, and that I lean on as well. So the thing that I say is, like, just be open, and I communicate what's going on.
Mm-hmm. Mm-hmm. So, Dr. Blue and Dana, so how do you prepare for or prepare your patients, or even think about what you might do, when patients come to you and you do their labs and you see that they're relapsing? So, like, what is your thought process, and how do you include the patient as part of the care team and thinking about what to do next? Or do you really anticipate, well, someday Natasha is going to relapse and we'll have to think about what to do after that? Is that something that you really think about and plan for your patients?
Well, I would say, if patients are relapsing and, they're coming in, we're discussing possible, new treatment regimen, being hopeful. There's multiple lines of therapy. So I know it's scary. It's not, oh, I'm relapsing, but there's so many options out there, and different treatments that we can use. So just being supportive and, being hopeful. The patient just needs to continue to be hopeful and optimistic that, okay, this line of therapy is going to work and it's going to keep my disease under control for a long time. And I just say optimism. This
Yeah.
disease is incurable right now, but they're making strides, and new treatments come out all the time. So I just
Yeah,
think,
that's true. Mm-hmm.
be hopeful and optimistic.
Mm-hmm.
Yeah, I would just say, I would tell anybody who is trying to answer the question, how do I prepare for relapse? I would say three things. Number one, I would say make sure that you are going to continue to get your myeloma numbers checked. I think that's something that people sometimes get very comfortable, and I
Mm-hmm.
think sometimes they too long goes by without the myeloma numbers getting checked, and things happen. So I
Yeah.
would say that's number one, making sure
Mm-hmm.
that whatever is happening, you at least are getting those checked on some type of regular basis. I would say number two, make sure again that you're listening to your body, right? There are things that happen that you need to tell somebody about and not dismiss. Okay, if your body's telling you something, especially if that thing just kind of won't go away, you need to make sure your care team knows about it. Sometimes people, their brain almost doesn't want allow them to think that way,
Mm-hmm.
or they think it's a negative thought. But it's like, no, we need
Yeah.
to know, because that's the only way that we're going to be able to help.
Right.
I would say
Mm-hmm.
that's number two. Then I would say number three, kind of what Natasha was saying, I think you got to remember to live life. When the disease is in remission, you should be, whatever your thing is to do, you should be living, right? Because there will come a time where you will be back so connected to the medical system, if not weekly or every other week, you'll be here very frequently for treatment. So the period of time that you get to kind of be disconnected from the medical system is typically when the disease is in remission. So
Mm-hmm.
use that time to travel, use that time to, whatever you enjoy, you know what I mean? And so those would be the three things that I would tell people to always remember, because again, we are making progress with this disease. We just, haven't reached that point yet where that once it's down, it stays down forever, and we reach
Yeah.
that really good curve. But we're optimistic, like Dana said, that it's coming.
Yeah. Agree. So, and I think that in this field in the myeloma community, we're very fortunate with the number of new drugs that have been approved just over the past few years, and the upcoming approvals, which are pretty amazing. There's some amazing stuff in the pipeline. So I think it's really something for patients to keep in mind, like you said, to continue to live their life and realize that there is hope. So very important stuff. So Okay, so I think we're here basically at the top of the hour almost. So now on behalf of the MMRF, I'd like to thank Dr. Blue and Dana Spiak and Natasha for joining me today. I'd also like to thank everyone for taking time out of their day to watch this broadcast. And finally, I'd like to thank Adaptive, Genentech, GlaxoSmithKline, Janssen, Karyopharm, and Takeda for their sponsorship of this educational session. If you have additional questions about what you heard today, please make sure to call our MMRF Patient Navigation Center at 1-888-841-6673. Thanks again, everybody, and that concludes our broadcast for today. Bye-bye.